Hello, my name is Mark. I'm a GP. This series of brief videos are designed to support learning on evidence-based medicine, specifically for GP trainees. It's certainly not exhaustive, but it is designed as a basic or a minimum knowledge requirement on EBM. But also before GP trainees should consider quality improvement projects or research projects. This sample curriculum is to support GP trainees interested in learning about evidence-based medicine and also before a research project or QI or audit is performed. The first video in the series today will be on the basics of evidence-based medicine. Later videos will then go through therapies, risk factors, diagnosis, screening, over-medicalization, data, and lastly, how to conduct research and audit as a GP trainee. So let's get started on the basics of evidence-based medicine. So the learning outcomes. At the end of this video, you should understand why EBM is important. You should understand how it fits into the consultation. We'll go through the core concepts and definitions of evidence-based medicine. We'll discuss study design, the hierarchy of evidence, the 4 steps of evidence-based medicine, the 4 A's, this concept PICO, and we'll also lastly mention how evidence is used in general practice guidelines. So we're very familiar with this. We engage in it every 15 minutes of our careers, and we, in general practice and in medicine, the simple medical student biomedical pathway of history exam, differential and management has been kind of superseded by models of supporting the consultation, the patient and ourselves through this very complicated process, the consultation. And we engage in just thousands of these in our careers. And where exactly, this is Calgary Cambridge, which is one model that we use to support our learning and our development in the consultation. Where does EBM fit in the consultation? I'm going to discuss 5 concepts here. One is we try and achieve a diagnosis sometimes, and there's a lot of uncertainty that we know about and we'll learn about later on in a later video. But we might use symptoms or signs or certain laboratory values and we try and come up with a diagnosis. And there's a science behind that, and we'll try and discuss that in a later video. Another aspect that we utilize in terms of the science of our everyday practice relates to considering risk factors. Think about primary prevention of cardiovascular disease. There might be aspects of the history, signs, tests, and we might want to use a prediction rule or a clinical prediction rule to try and support our management of patients. We'll discuss risk factors which come from observational studies and cohort studies at a later video. A core function, or what we'd like it to be, of medicine is that we want to try and help patients through specific treatments, therapies, drugs, non-drug therapies, and we want to help patients. And we will go through treatments in a later video. We also want to detect conditions in their pre-symptomatic clinical phase in an attempt to kind of help the patient, hopefully, and we'll talk about screening. And sometimes these things can go wrong in terms of underuse, but also over-medicalization. And this is a really serious problem in all health systems, and we're going to discuss this in a later video. And you have to understand the previous concepts if we want to understand how to address over-medicalization. So that's how evidence-based medicine fits into the consultation. This schema underpins all evidence-based medicine learning in terms of the science of medicine, the science of general practice. We want to understand in terms of diagnosis, prognosis, therapies. We're always thinking, how is this exposure related to this outcome? To get a tiny bit more technical, there are often 2 groups, as always in science, and we want to compare how an exposure is associated with an outcome in one group compared to another, and we try and see if there's a risk difference, and that might tell us something. An exposure or an intervention are often synonymous in EBM, and we'll get onto that when we talk about observational and experimental studies. And obviously this plays out over time. An exposure happens first and then an outcome happens later. In terms of critical appraisal, all studies can be biased, and that's okay. That does impact their validity, and we need to be able to appraise that to understand, should we apply this to patients? And another important aspect, particularly in relation to observational studies, is confounding. We'll discuss that on the next slide. So what are examples of exposures, and what are examples of outcomes? Examples of exposures. Well, really, they could be anything. So a healthcare professional may have postulated, is hypertension associated with cerebrovascular disease back in the day, and engaged in a research study. So in that case, hypertension is the exposure and cerebrovascular disease will be the outcome. But the exposure could also be a number, like a laboratory investigation, like total cholesterol. It could be a drug. In that case, it might be an intervention. Or it could be a more complicated measure, such as an adverse child experience. And that gets into the realm of, it can be quite hard to measure things, and only things that can be measured can be an exposure or an outcome. Examples of outcomes. We'll talk about outcomes in a later video, and I'm not going to go through the different types of data. For example, number type data or categorical data or binary data. In general, it's useful to think of, firstly, mortality and death being a really important, obviously, marker of an outcome for a patient, and it's relatively straightforward to measure. Markers of morbidity are another type of clinical outcome. For example, an MI or a stroke. A surrogate outcome is an outcome, for example, you might be interested in heart disease, but you might measure total cholesterol and assume that total cholesterol could be associated with a myocardial infarction, but it might not necessarily be. So you're using it as a surrogate for another outcome. And we have to be careful with that. Composite outcomes are when lots of different endpoints are combined together for an overall endpoint, and that can be useful for certain study investigators, but can make it quite complicated when you're looking at a study. So it's an overall composite outcome of multiple different sub-outcomes. But what really matters, a patient probably isn't that interested in a peak expiratory flow rate. That means nothing to them. But what matters to them would be maybe a marker such as the quality of life or pain. And these are patient important or outcomes, and they're often called PROMs or patient reported outcome measures. There's lots of other types of outcomes. For example, health economics. You might want to, there's a whole health services research discipline that will support analysis of cost effectiveness based upon clinical studies. So they're the examples of exposures and outcomes. So what is confounding? So let's say we find an association between an exposure and an outcome. Great, that must be the causal pathway. Well, not necessarily so. Confounding might be at play, and a confounder is a variable that is independently associated with the exposure and also the outcome, and it could explain the association between the exposure and the outcome. It's one reason why the term association does not equal causation is used. It is an unknown, and it might be something that is a socioeconomic variable, a community-based variable, something that wasn't measured by the study investigators, and that's a phenomenon that wasn't measured, and it's the actual explanation. And all observational studies are prone to this phenomenon. So just to say, the reason why we use randomized control trials is that when we randomly assign patients into two groups, and let's say that randomization was effective and wasn't biased, the confounding variables are also randomly assigned in equal amounts to the two groups. So randomization, in theory, eliminates confounding, and that is the reason why a randomized control trial is used if we want to assess a therapy. So we don't believe a cohort study, which we'll talk about now, or an observational study. We don't believe those associations when it comes to drugs. It's not a high enough bar for us to use in our patients. We need a randomized trial. So what is evidence-based medicine? The definition is it requires integration of best research evidence with our clinical expertise and our patients' unique values and circumstances. So there are three parts. Our clinical skills, our experience, they are really important. They must be used. Who's better than GPs to understand patients' values and circumstances? So we're meant to integrate the patient's wishes, their concerns, their ideas into any decision. And the third component of evidence-based medicine is utilizing the best research evidence. And if we had a specific paper or a specific question, we'd like to answer: is it important? Is the diagnostic test accurate? Is the medication effective? Is the prognostic marker accurate? But secondly, we want to assess in our critical appraisal biases, and we want to understand is that paper valid? And collectively, that process can hopefully support shared decision making, which I think is at the heart of every consultation. And GP is obviously really well placed to do this because we have continuity and relationships with our patients. Why does it matter? Well, it's the science of our therapies, of our risk factors, of our tests. That's what's meant to differentiate us from complementary and alternative therapies. And if we don't understand that science, I guess that really does impact our discipline. So it really matters. It is this, it isn't everything. Obviously, there are so many holistic and social aspects to the discipline of medicine, and in particular general practice. But of course, the science aspect of our therapies in particular, we must have a really rigorous approach to understanding that. And evidence is at the heart of medicine, or at least it's meant to be, and we're therefore meant to really understand it, and that's why it matters. It also matters because research repeatedly shows that doctors' literacy in evidence-based medicine is not that great, and I guess that impacts informed consent potentially. So moving on to study design. I've alluded to this already, but there are two main types of studies. There are those studies where the study investigators actually introduce something into the population. So you need a really high bar in terms of ethical approval. We are doing something to the study population. We're introducing a drug. And that exposure or intervention could be a drug, it could be a complex intervention. And I've already mentioned that a randomized control trial is the kind of gold standard way of assessing the effectiveness of such an exposure or intervention. I've also mentioned that randomized control trials are useful because they can eliminate the concept of confounding, which is present in observational studies. So in an observational study, the study investigators sit back, they don't intervene in the population, they just observe the population. They observe exposures, they observe outcomes, and a statistical analysis will unfold where we try and compare the two groups to each other. Depending on what is measured first, we have a cohort study or a case control study. So if we measure the exposure first and then the outcome later, that is called a cohort study. So let's start with a case control study. And let's use smoking as an idea. So let's say we have this played out in the 1950s. So let's say we're interested in thinking about the effect of smoking on lung cancer. So we identify patients who have lung cancer. They're the cases. And then we get controls. So these are matched individuals, maybe in terms of gender and age. And so this is the outcome. Patients have lung cancer or don't. And then we go back in time, and we probably through a survey, and we ask those patients, did you smoke in the past? So we assess the exposure, which might be smoking in this research question. Then you compare the rates of smoking to lung cancer in both groups, and that's called an odds ratio for a case control study. We can't infer causality, it's only an association. And we can also see there's obvious other biases that impact the validity here. There might be recall bias. A person who smokes might be more, or with lung cancer might be more likely to say, yeah, I smoked in the past. So Dahl and Hill did this, and the smoking lobby come out and say, I don't believe this. Sure, there's loads of biases. So you can now see that there's a hierarchy of evidence at play. The researchers decided, okay, well look, if you really want to believe this association, we'll start off, we'll get thousands of people and we'll follow them up over time. And we'll look at people who have the exposure, smokers. We'll look at those who don't smoke, so they're controls, non-exposed. And over time, we wait for the outcome to happen, lung cancer, in both groups, and we get a risk, and that's called a risk ratio. There's still confounding at play. We might not be able to believe as causal the association, but a cohort study is a stronger test of association compared to case control studies. And this is exactly what happened with the British doctor study, where thousands of male doctors were followed up over many years. So in terms of hierarchy of evidence, we can see here that at the top we have a randomized control trial. We'd believe that. Then a cohort study, then a case control study. A cross-sectional study would involve the exposure and outcome being measured at the same time, and you might have an idea of time frames. An ecological study, just to say, that would be where the data would not be at the patient level. So for example, let's say you wanted to know, is are asthma rates impacted by the pollution in the air? So you'd look at overall pollution in Dublin and in Galway, and then you'd look at admissions to a few Dublin hospitals for asthma attacks and acute asthma attacks in Galway as well, and you get a rough ratio, and there'll be a published paper, it'll hit the media. But actually, do you really believe that association? There's so many biases, and also it's not patient level data, and that is called the ecological fallacy. So you don't necessarily believe an ecological study. And below an ecological study are case series, so you can't believe that in terms of causal association. And below that are opinions, even from eminent persons in medicine. So above a randomized control trial is a systematic review. And systematic review are studies of studies. So they can be a study of randomized controlled trials, or if the research question was an observational one, it could be a systematic review of cohort studies. I would say that the hierarchy of evidence does not overlook the fact that you could have a really badly run, biased, randomized control trial, and you could have an excellent cohort study, and one might believe the cohort study more than that randomized control trial. So biases are certainly implicit in this, so we need to critically appraise research. In the GP guidelines, so let's just say in the migraine guideline, there's a line that says topiramate should be used for migraine for prophylaxis. There will have to be some qualification. How effective was it? What in which patients? And were there biases in that randomized trial? So usually in a clinical guideline, you will have in brackets a certain grade or level of evidence that will reflect this is systematic review, multiple randomized control trials, really high quality evidence, or maybe we recommend this, but there's actually totally uncertain and low quality of evidence. So in our clinical guidelines, we can, this is summarized by levels and quality of evidence, and this will be stipulated at the start of each clinical guideline. So it's important we're aware of that. Okay, we've also alluded to this, so it's getting a bit easier. But if you had a therapeutic question, does this drug improve this outcome? The best study to answer that question would be a randomized trial or a systematic review of randomized trials. If you were interested in, what is the risk, this exposure, is it linked to this outcome? The best study would be a cohort study. And diagnostic questions are a little bit more complicated, but you might use a cross-sectional study, but even randomized trials could be used to look at the impact of a diagnostic test. Okay, we're getting towards the end soon enough. So what are the 4 steps in evidence-based medicine? So if you have a question, right, does this drug work? We need to convert that clinical question into an answerable research question, and we use PICO to do that. We'll talk about that in the next slide. You look that up in the relevant place, and that is typically a secondary summary source of evidence, such as UpToDate or some sort of clinical guideline or something like that, a compendium of all the evidence. But it could also be looking up PubMed or looking up Cochrane and getting a specific paper and appraising that paper. So then you will answer the question, and that's called critical appraisal. There's 2 sides of critical appraisal. We've alluded to this already. First of all, you want to assess, is it valid? Is it biased? So can I trust it? And the second aspect is, well, what's the number? How effective is that drug? How large? What's the quantity of that risk factor? And they're the 2 components in critical appraisal. And lastly, we share that or apply it to the clinical situation. All right. So before we engage in EBM, we have to understand study design, and we've done that. And now we just need to go through what PICO is. So PICO is we want to answer a certain clinical question, and that's what research aims to do. So the clinical query can be framed in this format. So P stands for population, I is either intervention or exposure, C would be a control, so there's a comparison of an exposure group to a control group, and O is outcome. And then we flip those 4 concepts into a sentence. So does the intervention improve an outcome for a population compared to the control? The population should be the specific patient group we're dealing with, and the rest speak for themselves. In terms of control, the control doesn't have to be placebo or no treatment. It could be conventional treatment. So let's say we have someone in their 60s who's taking a beta blocker, and they want to know, like, do I really need to take this? And you say, okay, I'm going to look this up. There might be a systematic review of randomized trials here, but I'm going to try and come up with a PICO. So the population would be middle-aged men with heart failure. The I would be beta blockers. C would be maybe a placebo. O would be mortality. So we also know that this is a therapeutic question, best answered with a randomized trial. So do beta blockers improve survival in middle-aged men compared to placebo? So that is an example of a PICO, or the first A in the 4 steps of evidence-based medicine. Okay, so we finished the session. So hopefully now, at the end of this, you have learned why EBM is important, how it fits into the consultation, the core concepts and definition. We've discussed study design, the hierarchy of evidence, the steps, the 4 steps of EBM, PICO, and we discussed levels. We've mentioned levels and grades of evidence. So thanks very much for watching this video, and the next video will relate to therapies. Thanks. A few references here.